Well, hello. I'm State Representative Paul Baumbach. It is Sunday, April 23rd, about 4 p.m. East Coast time. And it looks like it's time to have let's see if we can level that out a little bit, time for a weekend update, if you will, for Delaware state employee health benefit status. So this all began, I guess you can say, in August of last year. The state, starting in June of last year, announced a planned change for the healthcare um, provided to state retirees, both those before age of Medicare uh, and also Medicare eligible and beyond. And the change was not popular. There was a lawsuit filed, and this became a hot topic. The lawsuit led to a judge declaring that the planned change had to be put on hold, and we've been using the previous plan, known as Medicville, ever since. The legislature, formed a subcommittee to explore all the options available to the state going forward and make recommendations. I serve as a co-vice chair along with Senator Brian Townsend, and it's chaired by Lieutenant Governor Bethany Hall Long. We've had near weekly meetings, I think, since the beginning of March, and we had one last week. We have one this week. So I wanted to go over what's been going on recently, what is coming up. Actually, most importantly, look a little bit backward and a little bit forward. Let's start looking backward. So we had, let me see. So if I'm going to pull up my screen, and there you go. I'll take questions at the end. I am putting in my email address in case you have follow-up questions or specific questions I can try to field. So we had some presentations at last week's meeting. These slides were available in advance. I think I went over these last Sunday, but I just want to point to a few items on this. So OPEB is the non-pension part of retirement that the state provides. So it's everything other than pension. And what we've promised retirees and the money we've set aside or set to provide is very different. As a matter of fact, there's about a $8 or $9 billion difference between what we've promised and what we've set aside. So we'll call that the OPEB liability. So we're looking at how we can, what steps we can take that would have an impact on reducing that liability. Lots of legalese. It's an $8.4 billion shortfall. And it depends how you measure it. And is it for people just in their pre-Medicare years? Is it people in their Medicare years? How's it broken down between those who are current employees and will be retirees, those who are pre-Medicare retirees and will become Medicare retirees, and those who are currently and will remain Medicare retirees? Lots of ways to slice and dice it. It keeps coming up with the same number, $8.355 billion. It does matter how you slice and dice it. And I think one of the issues that I've noticed is that we have I found it surprisingly generous retiree health benefit for people before they turn 65. A lot of companies, and the state of Delaware is not a for-profit company, but a lot of companies will have retiree benefits, but they wait until you turn 65 for you to be eligible for that. In the state of Delaware, you put enough years in, you're eligible even if you're 55 or even less. And that's very expensive for the state. So it's not terribly surprising this top figure here shows that about a third of the unfunded liability is attributed to those in the pre-Medicare years. So that's worthy of note. And it factors into where we're going. So what are different things we can look at? This looks at some of the history of things. The state began, and this is something that the predecessor to the Retiree Health Benefit Advisory Committee was the Retiree Benefit Study Committee. And one of the things that it recommended, and the parent organization, which is the State Employee Benefit Committee, SABC, adopted, was in the current fiscal year, last July 1st to this June 30th, we said about $49 million, or about 1% of the state budget, just to that liability. And the same thing is proposed for this upcoming year, is about $51, $52 million. So what does that do? Well, that if we were to do that for the next 30 years, we would fill about 60% of that $8.355 billion deficit. So more than half is done by that one step. Now, it means that every year, year after year after year, we take money off the table, 1%, 50 million and growing, out of the budget that we cannot use for our teachers and for our police officers and for our prisons and for our roads and everything else. 1% off the top comes out for that for 30 years. So that's a lot of money, but that gets us more than half of the way there. That is very interesting. What happens if we do it 2%? 93%. We get to 93% of filling that hole, of addressing that OPEB liability. And then if we did 3%, we'd more than fill it. That's pretty darn interesting. So when I started this back in, we formed in January and we started meeting in early March. I said, well, to me, we should have I look at it from a numbers perspective and I say, let's get a base case of how do we fill the hole, and then say, well, we can fill it this way, and it has costs, so it's good that it fills the hole, but it's bad that it has pain. So let's go. Okay, 3% fills everything. Job done. That's a lot of money, $150 million a year off the top and growing every year for this. It's a big hit. It's a big dollar hit. It means there's programs and services we won't have money for this year, next year, year after, etc. But we solve it. Okay, well, that's good to know. And if we back to 2%, we get 93% of the way, and 1%, 6% of the way. So we know how to fill it, one way to fill it. Now, what are other things that we could do so we don't have to do the full 3% or even the full 2%? That's what the later slides show us. So remember the, I'll say fairly generous health benefits we offer to those who retire before they're 65. And so this bottom line here says, well, what if we made sure that you had to be 60 before you got health benefits? Unless you're a retired state police officer, I think have mandatory retirement age well below 60. So maybe give them 55. If we were to, for future retirees, say you got to wait until 60 to get your benefits to kick in, your health benefits to kick in, even if after you've put in, say, 30 years of service, that would fill the gap by about 20%. And these other steps are all about a 20% reduction or in the hole, in the gap. So we can say that your spouse has to pay a share of the premium. So it's not just the state, paying it. And it can be, you got to wait more years to get a 50% share, and more years to get a 75%, more years to have the state paying 100% of the cost. So all these steps, each one of them would do about 20%. So say, well, okay, maybe we want to get one from this column, from this set of 4, and say, let's pull one of those guys over. Well, if we've got 20% from that, then we only need 80%, which means we don't even need to go to 2%. So maybe we need to go to 1.5% plus one of these pieces. We can solve the problem. Kind of interesting. I like knowing there's ways to do things. So, okay, we've got this one here on the benefits. So what's another way? Well, what if we do something with when you're retired, what kind of health benefit you have? Is it the Medic-Fill, which is sort of it's traditional Medicare supplement, but it's done without its own policy, but rather the state runs it. Someone administers it for the state. Or what if we use, I'll say that, the poison words, Medicare Advantage, which is not really on top of Medicare, but it is a form of Medicare. We'll call it a cousin of Medicare. That's one way to cut some things a bit. And the other choices would be able to get a traditional Medicare supplement, and typically states would do that through a health reimbursement account, an HRA. Those two, 25, 35%. Notice that of these two, the least impactful way would be to go to the Medicare Advantage, and this is really only Medicare Advantage. So that would get us partway there, but only partway there. The HRA probably has a little more savings in there, and this is something where you may do for future new hires. Who does it impact? There's always the question of grandfathering. these projections, I believe, indicate that they're I don't believe there's grandfather unless they explicitly say so. But what this tells me, I'm going to go back 2 slides. So if we just do the budget, we can get there, but it's going to take about 3% of the budget. But if we just take, say, 1.5%, and then we add one piece of removing a little bit of notable generosity in getting health benefits for those who are well under 65 in Delaware, that can do it. And maybe we can do a little bit of savings. Actually, we can. It appears, it's projected that we can do savings if we make a change of these two. My preference would certainly be the health reimbursement account and use a traditional Medicare supplement such as an F or G plan. And with that, if we did that, which was 35%, and we did the one of these guys is close to 20%. Say those two together is about half, so we need about half, which means we come in even under 1%. Ways to fill this. That $8.355 billion feels extremely impossible and gigantic. Well, it looks like we've got tools to get there. So at a high level, I like to see that we've got some choices in there, and I think the combination of them, probably a combination that gets us above 100%, and then back off with some grandfathering in there, if that makes sense. So make sure that the waiting until you turn a certain age to get health benefits. Well, let's grandfather those who are already retired but less than 65, and maybe those who are about to retire and still under 65. So get a glide path for these changes. That'll take some of the advantages, some of the closure to the gap out. So I think you put some pieces together that more than 100, and when you sort of become kinder in how you implement them, then you'll shave off some and get down to that 100. And actually, I'm not even convinced we need to get to 100%. I think if we get to 80% or something like that, I think that we'll end up with we'll be good enough, and we can fine tune it 10 years out, 15 years out, because these are long-term projections. An awful lot can happen. The rate of inflation in retiree healthcare, the rate of growth in state government revenues and expenses. A lot of things can change. Interest rates can change. So it's inaccurate to think we've got accuracy here. It's foolish to think we have accuracy. These are just current projections. A lot of unknown in there. So I think we want to make notable, measurable, dependable progress, but also recognize that we don't have full precision in there. And so that's this thing. And I see a question from Pat. And I do understand that not everyone is. This goes out on 3 different feeds within Facebook. Some people may put a question in one. Well, you're only going to put a question in one feed. I see all of the questions. Not everyone does, so I'm going to repeat it. So Pat asks, is your sense that the committee is in favor of grandfathering? You speak positively, but I haven't heard it discussed in an RHBAS meeting. Pat, that's a very, very good question. I don't think we've taken any votes. So I certainly can't say that you've missed anything there. Reading the room, if you will, it's, we've got both in person and probably the majority of our members most often are coming in virtually. I think that grandfathering, I'll say grandfathering means different things to different people. And what I mean by that, let's get this over here. What we mean by that is grandfathering, to me, in the context I just shared, has to do with if we're changing when you're eligible for retiree health benefits. So if you retire at 54, do you need to wait 1 year, 6 years, or 11 years to get health benefits? That's that grandfathering that I'm talking about. If we're cutting back that between retirement and 65, and maybe you need 25 years to get all of that, or all those formulas. Do we slide in and say only those who were born after such and such, or who started their employment after such and such, do these changes affect? So that's, and I'm really talking about that window in there. And that's what I mean by grandfathering. But there's also people who use grandfathering to say, okay, you're talking about the health reimbursement account. How about if you only do that for new retirees? So if anyone is currently enrolled in MedicFill, then they're going to have MedicFill as far as the eye can see. But the new folks will get something different. That current retirees get MedicFill forever. That's also known as grandfathering. And I think there are some on the committee who favor grandfathering in both senses and for both categories, both of that, how free retirees are have their qualifications adjusted with grandfathering, and others regarding how we deliver through a MedicFill or Medicare supplement through a health reimbursement account, for instance. I think there are committee members, my sense is there are committee members who prefer grandfathering in all things. Some are more open to it in one versus the other. We haven't, and Pat, really, you're raising a great question. We've been busy. we've had a whole bunch of meetings. Most task forces meet, monthly, if that. We're meeting weekly, and I'm not complaining. I'm just saying we've done a lot of work, and yet we still haven't had time to dig into so what's the implications if we go to an HRA, but we grandfather all the current folks to use essentially a MedicFill going forward? Is that really costly? Is it, somewhat saving, not as much as you'd have normal if you moved everyone to an HRA? Great question. And frankly, to answer your question on that one, on grandfathering, my sense is that the members of the committee likely don't have a set opinion of yes, grandfathering, no grandfathering, until they know what the implications are. And we haven't asked that question and got that answer yet. So I'll leave it there. Let me go to another presentation that was provided on the 17th. Yeah, this guy here. So let's put it up on the screen. There you go. And this one I really like. So during late March, early April, subcommittee members started flooding the Division of Department of Human Resources with, we'd like to know this, we'd like to know this, we'd like to know this, we'd like to know this. And one of the things, we had a slide a while ago that said, for a typical retiree, here's what happens under MedicFill. If we were to go to Medicare Advantage, here's what the cost would be. And if we went to a Medicare supplement, here's the cost would be. And I don't think I was alone in saying, that's really useful to know what the average retiree would have. Well, what about the healthiest retiree? And what about the sickest retiree? What about those with the lowest health, I'll say, interactions with the healthcare industry, and those with the most interactions? So that was one of our questions we really wanted to see. And I showed it last week. I may have shown something similar the week before. I really like it, so I'm going to show it one more time. So lots of legalese and there's presentations. Frankly, I haven't dug into this. There are changes coming to Medicare, including prescription drugs, and it's not on the main path for what we're studying, so I haven't dug into it. So I'll admit there. So skip all that. Medigap F. There's a question as to, there's F and G. They're very similar. But one of the things is that F is not offered if you turn 65 after January 1st of 2020. So the question is, well, so how many would be eligible? And the answer is about 2/3 of current retirees are eligible for F because they're of that age. But keep in mind, like every new retiree is younger than that and will be ineligible for F. So that the percentage right now is 66%, and almost by definition, it will fall year by year by year. And that's neither good nor bad, it just is. And details. Okay, so let me jump to the middle one. So this is that graph I was talking about. And this is the 50th percentile. So this is the average individual who's covered by Delaware state employee retiree healthcare costs. And this is someone who's Medicare age. Okay, so they're currently coming down, being covered by MedicFill. And what you see is the state pays somewhere around $5,000, $4,900. And there's some out-of-pocket costs. It's really just about all for prescriptions at about $400. And depending on how many years of service, maybe spouse and such, the retiree may be paying somewhere around $276. This is per year. So the average total cost in there, let's say 400 to 600, we'll average at 500. It's around $5,400. And that's more than either of the other two groups of columns. So far right, Medicare Advantage, that's what the MA stands for. And it's around $1,000 to $1,300 a year, whether it's paid by the state, the employee, or some combination. And those costs are large, well, it's both medical and prescription, but there's no direct premium. There's no premium, and there's a whole long story about that frankly doesn't matter at this point. Total cost to both combined state and retirees, $1,100 to $1,300, much less than for MedicFill. And then a Medigap would be somewhere in the middle. And for this, the Class F or Class G, which is very, very similar to MedicFill, truly, not just someone told you that, truly very similar to MedicFill, you have somewhere around $3,200, $3,400. So this is one where this Medigap, least expensive, Medicare Advantage, next least, Medicare, Medigap, F or G, most expensive, MedicFill. Okay, well, what happens for the really healthy retiree? So here, 10th percentile. So 90% of people, Medicare age and above, who are state retirees, 90% use more expensive healthcare than this person, this theoretical person. Total costs around $200, and a little bit of prescriptions, a little bit of copays here and there. If you're in MedicFill, you're paying between $200 and $500. Again, some of that cost is just if you have, because you haven't worked as many years, you're paying some of the premium yourself. But the state keeps paying that $4,900, even though this is a very healthy person. And then, so the cheapest, Medicare Advantage, as it was for the middle, 50 percentile. And then the next cheapest is this Medigap F or G at about $2,100, $2,200. And then most expensive is this MedicFill. So then what happens for the individual who has the highest costs, has higher costs than 90% of retirees, Medicare age retirees? So here, what you see is that pretty much MedicFill and Medigap FG are about identical, somewhere around that $5,500, $5,900, in that range. And both MedicFill and Medigap FG are about the same in there. But whoa, got some high costs over here at Medicare Advantage, $6,300 to almost $8,000. So we've heard anecdotally that Medicare Advantage is not bad when you're healthy, and it's pretty much less good when you're unhealthy. And this chart really just reinforces that. Okay, so Sharon says, for those who've already worked 20 plus years for the state and thought they'd already earned benefits, will they be grandfathered? Sharon, wonderful question. And unfortunately, the very clear answer is we don't know. But what I will say is I do expect, it is our charge as a Retiree Health Benefits Advisory Subcommittee to make advisory subcommittee to look at that question, answer that question, and share that with the governor and with the legislature, and essentially also with the State Employee Benefit Committee, the SEBC. So that question of grandfathering is extremely important. What my horse sense, another way of saying I don't know, is you can't count on it, but that if we are looking to take benefits that people have been counting on, especially for 20 plus years, as you ask in your question, much less likely that we would have this affect somebody who is that close to retirement, that close to retirement decisions. Much more likely that we'd have it those who are going to be working 10 years or less, maybe even 15 years or less. But I think that the more years you have, the much less likely it is that at least we'd be recommending that a change be made that would hurt what you had been, that would reduce what you've been counting on and been told to expect. So it's a great question, and that's part of what we need to be looking into. Getting back, let me see if there's anything else here. Nope, I'm going to ignore all that. So let's go to what is happening on Monday, which will be tomorrow. So the RHBAS, the State Retiree Health Benefits Advisory Subcommittee, is a subcommittee of the SEBC, the State Employee Benefits Committee, which meets tomorrow. So from 2 to 4 p.m. tomorrow, and there's some Teams information. If you have any questions, you can go to You can look at Delaware SABC meetings or something like that, and you'll find this. So it has a link to live stream it, and you can also raise your hand, ask questions. No, not ask questions. We don't answer questions during public comment. You share your public comment. It goes into the record, and then the committee members have that to consider. So this is the agenda for tomorrow's meeting. And let me go through real quickly. Approves previous meeting minutes. See if there's any subcommittee updates, if the director has any updates. Look at the fund. This is the healthcare fund. So keep in mind the SABC does more than just retiree health benefits. Does a lot more. So sometimes it's looking at current employee health benefits and things like that. So 4 is looking at financials. 5 is looking at prescription drug plans. And here we go. Number 6 this affects me, so I'm going to look at number 6. So this subcommittee that I've been working on for 2 months now, the RHBAS, what are its updates? What's its progress towards? One of the things that was set up to do is provide a status report on May 1st, which you may remember. You're going to do the math and figure out that's pretty much that's a week away. So by next Monday, by Monday the 1st, we were supposed to have a report. So what's the progress on that? We'll talk about that separately, but they're going to be talking about this tomorrow. That's number 6. And then number 7 is a proposal to extend the current Medic-Phil retiree health benefit, the one that retirees are on right now, that currently is set to expire on December 31st of this year, and have it extended another 6 months to June 30th of next year. Now, why are they doing that? They're doing that because they don't have time to find another one by year end. First reason. Main reason. Okay. So they're pretty much forced to do that. But regardless, the SABC will be discussing and voting on whether to do that. It seems highly, highly likely, certainly expected. They'll be talking about that, discussing it then. What's the next thing? What are the rates going to be? So if we extend it past December 31st of this year, starting January 1st of next year, what are the rates? What's the state paying for Medic-Phil for the first half of next calendar year? Okay. Another really important part is if they extend it to June 30th, 2024, what's magical about June 30th of 2024? That is the end of the next fiscal year. We pass our budgets as a state in June to start on July 1st and to end the next June 30th. When this budget was first proposed by Governor Carney in January, it assumed that Medic-Phil would end on December 31st of this year, and we'd have something else on January 1st of 2024. So the governor in his budget, in his proposed budget, put in language to say, make sure you're covering that, you're doing that kind of stuff, and some assumption of what the costs were. There was also a paragraph known as an epilogue language paragraph that said, and you're going to be doing your new system as of January 1st. If the SCDC tomorrow says we're going to keep Medic-Phil going for 1 more year, then that changes the budget for next year, because it means that for the second half of the year, which is the first half of the next calendar year, we're going to be using Medic-Phil, where the current budget's been assuming, frankly, Medicare Advantage, which is the contract that was signed by the state and stopped by the judge. So if SCDC does this, that changes what's happening in next year's budget, which the legislature is working on right now and will be finalizing by June 30th. So it's a big thing if the SCDC does this. So all eyes are on the SCDC tomorrow from 2 to 4. And I'd say expect them to vote to extend it through June 30th. And that takes that scary language, alarming language about you're still moving towards that nasty Medicare Advantage thing. It probably takes out of having any reason to stay in the budget. Now, that said, the budget. What's the budget? The governor prepares a budget, shares it. It gets put pen to paper into a form that comes through the legislature. The leaders of the caucuses, the 10 leaders of the House and the Senate, both parties, sign on to this bill. It's just a pro forma sign on. It's the governor's budget. And then the Joint Finance Committee looks at every line and says, yes, keep it, take it out, adjust it. And they have all their hearings, especially during February, but also ongoing to do refinements as the financial picture changes and as, frankly, as legislators do new bills with new costs. But a change like this, where the state retiree health benefit changes for the second half of the year from January 1st to June 30th of next year, has a big impact on the budget, and that has to be incorporated one way or the other. It doesn't mean we're going to amend the bill and take that language out. The Joint Finance Committee works on let me back up. I don't serve in the Joint Finance Committee. They have their systems for, okay, we talked about this section of the code about DENREC, and we're planning to make these 5 changes, and they keep track of that. You're not going to see it in House Bill 75, which I think is the budget bill, but they're keeping track of everything they've said. Okay, we want to change the stuff that was in that original budget. It is likely, I find it likely, that after the SABC, if they choose to agree to extend Medicare for another 6 months, that the Joint Finance Committee will say, yep, you don't need that language anymore. You're not going to see amendment to take it out. But the Joint Finance Committee, I believe, would then say, no need for that. In our working version of it, it's gone. Now, before I go further, I'm going to see questions. All right, Sharon, you're welcome. Pat, I know the committee's charged for retiree benefits, but since the only OPEB expense is for healthcare, shouldn't the path to reducing the OPEB liability be considering an all-state financed healthcare? Are you getting any advice, projections, choices on that? Very good question. So I think you're talking about like a single payer health care, also known as maybe a Medicare for all or Medicaid for all. Pat, it's a great question. And indeed, RHBAS, the advisory subcommittee, is solely looking at health benefits, but only for state retirees as opposed to retirees who weren't state employees, and as opposed to those who aren't retired, one way or the other. Is there overlap? Absolutely. If we were to go to let's say a Canada system of a Medicare for all health benefit, or frankly, all the advanced economies in the world other than ours, would it make this much simpler? Absolutely. Is it something that we put together and make work in the next 2 years? Heck no. And therefore, we can't hold off on that. Frankly, I've seen bills, not in the past 2 months on this, but there are bills to do that. Some have come through the legislature and been looked at. I believe that retired Senator Harris McDowell had great interest in this. Certainly retired Representative John Kowalko had a great interest in this. Other colleagues do, current colleagues do also. But I don't think there's anything active in there, and certainly nothing that its timeline would enable it to jumpstart and leap into the fray here on state retiree health benefits. Henry says, Paul, at last town hall meeting last week's, someone's paying attention. Oh, I'm sorry. No. This is, okay. At last week's governor's town hall meeting, the governor was asked by Dennis Young why his administration was pushing for us to give up our Medicare. And he said he didn't see it that way because his plan wasn't, it's Medicare. He still refuses to acknowledge the Medicare Advantage means we're no longer under Medicare. Also, when Dennis told him that the state was responsible for 20%, he stated he did not know Medicare is 80% of our Medicare plan. How can the retirees' costs be the same as those under 65? He said he wasn't aware, I think. So I don't speak for the governor. And I'll say it is absolutely accurate to say that Medicare Advantage, first word is Medicare. It is under the Medicare system. It is considered a Medicare program, but it is quite different from a Medicare supplement, which is what we've come to understand for decades. It's pretty recent, and again, very different. So I understand there's a lot of retirees who have been very frustrated with the administration and its actions last year and its continued wording this year. So it's and I mean, frankly, we've been digging into this in the advisory subcommittee, and the governor's been doing a wide range of things. So he may or may not be as aware and in the trenches with the numbers as those who have been in and following the RSVAS, like many of us are. So how can the cost be the same as those under when he said wasn't aware? So yeah, so Henry, here's what I'm going to do. I'm going to pivot. I'm going to be a typical politician and pivot and say, you are pointing out the benefits of the Retiree Health Benefits Advisory Subcommittee. We've been able to dig. We've been able to explore, explain, present clearly, get help from outsiders, including those from Rise Delaware, for that getting information, coalescing it together, presenting it in an understandable way, really separating into those populations of what is the healthcare costs for active employees, what is it for retirees who aren't Medicare age, what is it for Medicare age retirees if they're under a Medic-Fill or under a Medicare supplement or under a Medicare Advantage. That level of digging in, we didn't have that 6 months ago. So I think this is really the silver lining. The lemonade we're making here is that we're learning a lot and we're becoming much better consumers of this whole topic. So I'm going to focus on the positive side of things. I think there's some whistling and some Monty Python tune coming to mind. So I'll leave that reference very vague. So other things that they're looking at their other subcommittees, value-based healthcare, again, stuff way beyond our HBAS stuff, public comment, possible executive session. So that is what they are doing. Their presentations, Health Fund against this current employees, looking at the different subcommittees, really not that germane to what we're looking at. So that brings us to this Wednesday, which is the next meeting of our subcommittee. And Pat, no, I understand. I'm sorry. Pat writes, because she was asking about wouldn't single payer really solve this kind of stuff. And she points out, I was just thinking overall cost, not quite revamping the entire health system. Getting advice projections. Let's see, all state financed healthcare. Yeah, I think that. So I'm sorry. I'm I'm delaying as I'm reading through and thinking about Pat's question. Let me read her original question again. I know the committee's charge is for retiree benefits, but since the only OPEB expense is for healthcare, shouldn't the path to reduce the OPEB liability be considering all state financed healthcare? Are you getting any advice, projections, choices on that, especially as it relates to adjusting the overall cost of the system? So let me answer it this way. We saw in an earlier chart, if we take 3% of the budget, $150 million a year, and increase with costs, that can solve the OPEB liability. So I would say, turn that around and say, to look at an alternative such as, well, let's do single payer healthcare for everyone in Delaware or all employees and retirees. For it to be a better way to address the liability, it would have to cost less than $150 million a year. I don't know of a current plan for that, that can deliver that. But it's also one that it's very involved and it hasn't been developed and presented in an actionable enough way at this point. But thank you for refining your question, helping me have to struggle through that important distinction in there. So meeting on Wednesday. So go over our minutes, May 1st. So again, we were established in January, and one of our tasks is to come up with a status report in a day, on May 1st to the legislature and the governor. And again, we are a subcommittee of the SCBC, so inherently also to the SCBC. So third item, status report. So we'll get I think you're going to see this by Tuesday when the material is posted, maybe even late Monday, a initial status report. And I expect that I've not seen it, by the way. I expect that it's going to be I think the Lieutenant Governor used some term like a skeleton. I sometimes use the term of a chassis. Generic, lots of placeholders, no specifics. But part of this is when this was drawn up in January, we thought we were going to need recommendations, hard recommendations on May 1st to give the state the ability to put an RFP out immediately. The SCDC put out an RFP immediately and get some bids in and award it in June or July and get everything ready to change on January 1st. We now know we don't expect that to happen. So we don't need to be anywhere near as specific as we thought we'd have to be by now when we passed the law in January to set this advisory subcommittee up with its requirement of doing a status report for May 1st. So it no longer has to be as precise and actionable because the timeline is shifting. But we should get a general piece there. And then what do we do? Before we even start talking about that, we're going to go to the public. And this is something I pressed for, is I want to have the public, and I'm hoping in the status report, this general and fairly thin status report, it's more of an outline, if you will, that's out ahead of time. And I want some members of the public, I want as many members of the public who are interested to read it. And anyone who wants to be in person or through putting your hands up, zooming in, and offer public comment, share your thoughts. Okay. And one may be, I'd like to see all language about Medicare Advantage taken out of the budget. Okay. I'd like to see some statement saying never have Medicare Advantage only as a choice for Delaware retirees, or whatever it has to be, whatever you feel. That is your opportunity for public comment before we finish that status report, which will be later on Wednesday. So you'll see the skeleton, hopefully a day ahead of time or more. Prepare your comments. Now, if someone said the same thing you wanted 2 people ago, don't take time to repeat it. But I'm hoping that the public will speak up and share their thoughts on either things in the status report that you think should be in there, or things that aren't there that you think should be in there. So please look at it, and if you have some input, please add that. Does the public mean non-state workers? So public comment is indeed public comment. Anyone in the public is allowed to speak up, whether they're a retiree, whether they're the spouse of a retiree, whether they're not a retiree, whether they live in Arizona and have never lived in Delaware in their entire life. It's open to the public. So yes, anyone can speak up. It is, I'll say, if I was a member of the public and if I was a state retiree, or let's say I was that, as Sharon mentioned, I've been working for 20 years and I was counting on at 25, I was going to retire, and I understood that I'd have this kind of, the state was paying this amount of my premium, and I was going to get that from that point until 65, and then I was going to get, some kind of supplement or benefit at that point, and say, look, I've got standing. Okay, this is hitting me directly. I care deeply about it. Here's what I want to see in the status report. Here's what I want you to take out of that draft status report, and please listen to me because this affects me deeply. Or say, you know what, I live in New Mexico and never been to Delaware in my life, but in New Mexico we have this thing, and I think it's worth you guys considering that. That's fine too. So public comments open to the public. Okay. Henry said, they do not realize we paid part of our salaries and medical expenses through our taxes. Sure. Frank, Henry writes as follows. They, presumably meaning non-state workers, do not realize we paid part of our salaries and medical expenses through our taxes. So I would characterize it differently. And this is how I look at it. Please don't, I'm not the authority. I'm one person on the committee. I view it more of the state has made a representation to our workers for decades saying, here are the rules of the road. And here's how we've been providing health benefits. Are we permitted to make changes? Sure. Hopefully, the state will think about us when making those changes and be reasonable. There's times we know when we all need to pull in our belts, and there's times the state may have to do that. But let's be honest with each other, transparent, and caring, and try to do it in a very respectful way. And certainly there's a view of most who work in public service, a recognition that private industry often pays more than public service does. And that's one of the trade-offs for the greater job security and often for the better retirement benefits. So it is a trade-off, and it has a cost during your working years, often a lower salary, and you hope to have the benefit of better retirement benefits by having chosen that path and foregone that higher salary path for one that has again, more stable employment and a better retirement package. So indeed, you got to consider the full package in there. And somebody who's not a state worker may not realize that. Indeed, that's a fair point. Pat asks, do you think there's anyone on the committee who doesn't know we are against Medicare Advantage? Oh my gosh. I have found that of those that I've interacted with on the subcommittee, not a single person lives under a rock. And I no way of saying, I think everyone understands. Everyone on the subcommittee understands Medicare Advantage has an awful lot of people who do not want it as their only choice. I think there's no question about that. For any member on the subcommittee, it's not that I've done a poll, not that I've asked people, hey, do you think that the public likes Medicare Advantage? And they say, sure. No, not had those conversations at all. But being at every committee meeting and hearing the public comment, there has never been people cheerleading Medicare Advantage outnumber those who are sharing deep concerns about Medicare Advantage. So no, I don't think there's anyone on the committee who is not aware that a large number of Delaware retirees, state employee retirees, are upset about Medicare Advantage. Recently in the Beta Gazette, a person commented that he has to pay for his why shouldn't we? Fair, absolutely fair. Thank you for sharing that, Henry. So apparently there's a letter to the editor where the person wrote the letter at the Bay Gazette, is it Bay Gazette? Back to Bay Gazette, Beta Bay Gazette, Sussex County, shared that, well, in private industry, you got to pay for your health care. Why shouldn't a retired public employee have to pay for their health benefits? As we said, these are package deals. It's a trade-off you make. You go to private industry, you accept that job. You know that there's no health benefits when you retire, if that's the case. And you say, I still want to take the job. You're offered a job with the state, working working in one of the schools, working in law enforcement, working in public health, at the state service center, whatever it happens to be. And you say, okay, so that's the salary you're offering. Okay. Stability. Okay. I get health benefit. I get a pension. Okay. Don't get a 401k paid by the company, but I can pay into do a pension. I can do a 403b, 457. Health benefits. That private company doesn't offer that. Okay. It's apples and oranges. And so, the person who wrote to in the Beta Bay Gazette is correct that private industry rarely pays health benefits in retirement, and the person's on their own to shop for and purchase their own Medicare supplement. That's what they knew when they took the job and started and had their career in industry. But the same thing is true when somebody works for the public sector, where they know that's part of the package. Just as a company wouldn't say, and frankly, it would be illegal to say, sure, you get a 401k and then you retire and say, oh, actually, we're going to take all that money. You can't do that. And similarly, when the state says you got a pension, they can't take that pension away. And health benefits are not as crystal clear, but the main thing is that was part of the package. And our public employees, when they're working, know that the state has always said, you're going to have your healthcare benefits in retirement. So indeed, it's apples and oranges. So may have been a little bit less information that the writer understood than most people here do. So my concern might go into the public. So Anne Marie is pointing out that when you open things up to public comment, you can have people who are maybe less versed in the full range of factors going on. Look, I'm a public official, I'm a legislator. I hear a lot from the public. And there's extremely well-informed people. There's people who are better informed than me on issues that they write about. And there's people who are less informed than me on issues that they write about. Frankly, I think it's our responsibility to be able to filter that. We still need to listen to all of it. But we need to say, oh, okay, I understand your point. And you feel that since you have to pay for your own retiree health care, our employees who work 30 years for the state were told they would get it. They don't deserve it. Thank you for sharing that. And I understand that perspective. Doesn't mean I agree with it, but that's, that member of the public has the same right as you do to share their opinion. And, it's our responsibility as members of the subcommittee to take all that into account. Our healthcare is deferred compensation. Our healthcare is deferred compensation. So that's an interesting point, Pat. So, deferred compensation is typically, you can think of it like a 401k or 457 or 403b. You say, take 10% of my pay, and instead of paying me $50,000 a year, pay me $45,000. That $5,000 a year goes into my retirement account, and then when I retire, I take it out as income. So that's deferred compensation. You said instead of taking it in my 50s, I'm going to take it in my 70s. And Pat points out, retiree health benefits, it's sort of the same thing. You say, I'm going to take less income. I'm going to work for the state, which is not the most generous employer as far as pay goes. So I'll take a little less pay then, but I know that I'm going to get a stream of income through the provision of retiree health benefits when I retire. I'll take less income in my 50s so that I have this benefit in my 70s. It is indeed. That's a good point. So, Pat, as you say, your health care as a Delaware retiree is a form of deferred compensation. Really good point. I like that. Kathy, you are welcome. Kathy says, thank you for presenting all of this to us. My pleasure. I will, as much as I love this and I love you all, I'm not going to mind when the work's done. And I may even take a Sunday off now or then. But I still think there's new information coming. I think we're going to slow down, maybe only 2 meetings a month in May and maybe June also. We will take a little breather. I'll be able to maybe not do weekly updates, so we'll see how that goes. Pat, you'll miss us. You have a high pain threshold, but we'll see how that goes. As long as they have the facts and understand how we pay the very taxes that they do, but those taxes pay our salaries and healthcare. Yeah, Henry, I think, and this is something that I've really come along to understand more deeply, is, I view that if you take our full collection of retirees, including those who retired 2 days ago, and those who retired 20 years ago, regardless, for them to have benefits, they've worked a number of years for the state, 10, 20, 30, 40 years for the state of Delaware. And they did that, as Pat would say, with a deferred compensation trade-off of saying, I know I'm not getting top dollar, but I also know you're telling me I'm going to get retiree health benefits. And so we said, yeah, we're going to have retiree health benefits, and we never put money aside. Or certainly nowhere near the money we needed to put aside. We said, oh, we'll get to it when we have to pay it. And that just isn't working out. So we absolutely need to catch up to that. And it's our obligation. And for that retirees who worked 40 years for us and maybe is 20 years in retirement, we need to pay for their health benefits. And we got the state, the taxpayers, receive benefits from that employee for their 20, 30, 40 years of service to the state. And we got that benefit without paying them top dollar. We have an obligation. We have an obligation to live up to our promises and deliver retiree health benefits. We can argue, we can discuss, we can explore do we need to give a 45-year-old with 25 years of service health benefits at 45, or can we wait till 55 or 60 or 65? We can have those discussions. That's worthwhile. But when they're 65, we need to be giving them. We need to be giving them something above Medicare alone, in my mind. And so we'll see. Anyway, I'm 40 years old. I've heard it over and over that we shouldn't get it. You need to be You need to surround yourself with other people. If you're being told that a state employee does not deserve retiree health benefits, I'm sorry. I'm sorry. Our state employees make the state run. You look at the last blizzard, and we knew that there were Delaware employees working literally around the clock, clearing our roads, making it safe. The Division of Public Health employees were working also around the clock, 365 days a year to keep us as safe as possible from a global pandemic. We owe them. We owe them to deliver on our promises. And I am sorry if you are hearing from others that we don't, it's not our responsibility to live up to our promises. That's disappointing. Disappointing is my code word for I'm really pissed off. I'm really disappointed at that. Commonly heard statistic, including from Secretary DeMatteis, is that we can expect to see 95% of our health expenses in the last 5% of our lives. And I'm not sure of that number, but I think it's probably close. I wouldn't. There may be some there may be some footnotes to that. It may be like of retiree health benefits from 65 to 95, that the vast majority is in your last 5 years of life. If that's true, shouldn't that be baked into the budget for insurance, starting from the original hire date to death and not treated as a surprise? So Pat, absolutely true. Yes, going forward, we need to make sure that we are saving as we go, not just paying as we go. Delaware, the state government, has treated retiree health benefits as a pay-go. If we incur $75 million of retiree health expenses this year, we'll pay it out of our operating account. Well, that's nice. What about another year worth of employees that have put time and worked for our state that are going to need money 20 years from now? What have we done this year to set money aside for that, to save for the obligations we now have for these people who have one more year of service with Delaware? That's where we failed. And we need to stop that failing. We need to get to that. So here we go. Let me see. Let me pull the thing out just to see if there's anything else to go over on the agenda for Wednesday. So public comment, then we discuss amongst the subcommittee. Then we're not answering public comment. Again, public comment is the public sharing their opinions. It's not a Q&A. It's not a question for the panel. It's this is my opinion. This is what I think. This is what I'd like to see you do. Okay, we then shut that down. Okay, we end public comment. And we don't normally do this. This is unusual, and I push for it. Then the subcommittee will talk amongst ourselves, and we'll say, okay, that one comment, I agree with that. Can we get that done? Talk amongst ourselves. Actually, only one person likes that. No one else likes this. We won't do that. Or, we've got a big consensus in favor of that. Let's add that to the draft report and refine the draft report and come up and say, okay, we think we've got a draft report that we might be able to get a majority of yes votes on. Let's do a vote and see if we can get it done. It should be a high level report. It should be more on big picture, longer time, because this isn't we think you're going out to RFP in the next 3 weeks, and therefore we're going to get some really specifics to you, but rather here's our sense. Here are the elements that we think we're going to be recommending that we do, and maybe some directions for the SCBC, maybe some directions for the legislature, maybe not. But we'll see, and then hopefully we get a vote on the status report and we can move forward. We still have some questions about how HRAs work, individual marketplace. So that's item number 7. We'll go into that. Maybe some additional, again, we've put this big wish list of, can you run this? Can you run that? So, item number 8 is, are there more scenarios that they've modeled that they can present the results to us? Number 9, guess what? You get to talk again. So that public comment number 4 is only about the draft status report for May 1st. Okay. If you have any other concerns, then hold it off and come back at number 9. That's public comment on anything that we're working on. But the public comment for number 4 is only about the proposed status report. And then we adjourn. Now, let me mention one thing, just so you know. The meeting is from 10 to noon. At 11 o'clock, I have 2 different bills and 2 different committees. I guess 2. I know one is a big one. So I'm going to be bopping in and out, and this will be the first meeting, I think, that I'm going to be virtual at, because I'm going to be in Lake Hall presenting a bill in a committee on the House floor at 11 o'clock. So I won't be there for the whole time because I got to do my other job also. So just to let you know, please, it's not because I don't care, it's because I've got 2 things that are both happening at the same time. So that's the prepared stuff. Let me just see if there's any last questions. Agreed on the fine tuning. Guess the state has taken out a balloon mortgage on our healthcare. And keep getting great descriptions of things. So yeah, it's a balloon mortgage. So we've said, oh yeah, we'll take this low interest loan on this thing that we're going to owe you later on, and we're not going to worry about it until 5 years. Oh my God, it's all due now. That's sort of where we are, and that's it's not good. But I'm glad we're not just talking about it, but we're really exploring what we can do about it and do about it quickly. And it quickly doesn't mean we're fixing it quickly. It means we're taking steps quickly so that in time we'll address it all. So we'll go there. You're most welcome, Anne-Marie. Debbie writes, if Carney still settled Medicare Advantage, which he appeared at the town hall meeting, he may veto the bill that doesn't include it. So Debbie, it is certainly the case that the governor is able to veto budgets and other bills that the legislature passes. The legislature has an opportunity to override vetoes that occur. On something like the budget, which it's really important. It has to do with whether the state can stay open for business. I'm in my 11th year now. I think we've only had one time where we didn't pass a budget the night of June 30th into July 1st. And we had to come back maybe 3 or 4 days later, and we found a path forward to get things going. It's extremely unlikely that we would have a budget for the governor that he would be vetoing. That would indicate a real failure to communicate. The leadership of both chambers, but all 4 caucuses regularly speak and meet with the governor. So there are as few surprises as we can manage. And the budget is just too important a topic to not be a regular topic of conversation, to make sure that we know where, if there's any bright lines in the sand, that, if we do this, then a veto is coming. And then we can say, well, okay, if veto comes on that, that view is unpopular enough that we would work to override it, and we think we've got the votes for it. We sort of saw that in the past week. I don't think that, Debbie, I understand the frustration at the choice of words that the governor used at his town hall this past week. And that it's possible to read into that material that I'm not reading into it. I do not see, for instance, if SCBC on Monday extends Medic-Fill through June 30th of next year, if the legislature by June 30th has a budget that has no mention of the contract for Medicare Advantage, I would be very, very surprised. Number one is it would not be done without ongoing discussions with the governor. It would not be a surprise to the governor. If the governor had a gigantic problem with that, all parties would work to see if that could be resolved. It wouldn't be a last minute change, and it wouldn't be a surprise from the governor. It would be something that was understood over time. So I'm going to say I'm not losing sleep over that piece. Okay. So Pat, you're most welcome for my answers and commitment. Debbie, hopefully legislators will override if it comes to that. My hope and prayer is that it doesn't come to that. And more than that, my expectation is that we don't come to that. I think we're at the end. You guys have hung in there for over an hour. I want to thank you. I do store this off on YouTube. It should be available on Facebook also. Have a good weekend. If you really have time and the interest, catch the SABC meeting tomorrow. Catch the RHVAS meeting as tomorrow afternoon. Catch the RHVAS meeting on Wednesday morning. And maybe by next Sunday, we've got some real developments to share. Okay? Thank you very much. Have a great end of your weekend.